Great, thanks, Becky. Obviously, from the description of this case, this is a severely injured small child, and there are a lot of things we need to take care of initially. What I'm going to talk about is the use of simulation, and really, just as this whole session is on multidisciplinary, the trauma team is a team, and how that team functions together really plays a role in our patients' outcomes. At Cincinnati, we've been using simulation for a little over 10 years now, starting with our ED team and then moving on to trauma. So we have some experience and certainly some learnings over time. Nothing to disclose. What I'll talk about today is kind of communication tools and how that impacts teamwork. Some of the impact of simulation training. How does that make us better? Does it make us better? And talk about latent safety threats and how do we learn from what we observe during simulation so that we can fix things before it reaches our patients, specifically our trauma patients. I'll throw out a question here just for people to think about, and feel free to comment in the online. But I'm always curious how many people have ever had formal training in teamwork and communication. I know myself, until we started doing this program, I had zero formal training in teamwork and communication. You've learned what you could on the fly in the operating room, in the ED, and from your partners. So as you're watching this, think about that question and do you think it would be any benefit to you? I'm going to show a quick video of a resuscitation that we staged, certainly, but want to get people's mind thinking about it.
Here's 7-year-old I've called about.
Hey, all right, can anybody get an assessment for me? Tell me what's going on. Can somebody place IV? Can someone get some pain medicine? I don't know, whatever you think he weighs. Yeah, let's get an IV and let's, I don't know, maybe 45, 55.
Yeah, I don't see.
Let me see what's going on.
Or something.
Oh wow!
Oh wow! You should probably put a chest tube in. Hey, we need to get to the OR probably. These guys are a bunch of idiots down here.
I think we're just too deep. I think we should just pull it out.
Yeah. Let's get some fluids,
right?
maybe. I don't care what kind you want to give.
Okay, IV's up and running. I'm drawing some.
Oh my God! Why the you guys pull that out?
It was too deep.
We were going to put a chest tube in.
I have lines drawn. How about our
All right. All right, so hopefully folks enjoyed that, and I'm guessing many of the surgeons, emergency room doctors, nurses on the line have experienced a trauma resuscitation somewhat like that. Hopefully as you've watched that, you came up with some opportunities in your own mind for how we can do this better. In that scenario, we clearly did not listen to what EMS had to offer. We didn't hear we kind of quickly dismissed them. Clearly a problem. We didn't direct our orders at individuals. There was no closed loop communication. I'll come back to that. When you say, can somebody, I know everyone on this panel is not named somebody. I know everyone in the audience is not named somebody. So no one listens. They always assume you're talking to someone else. Clearly, I didn't respect or listen to other team members, especially, I could say as a surgeon, I didn't respect in that video the ED providers and their input and wanting to get that patient out of there. And clearly the team was not on the same page. Someone pulled the ET tube when the rest of us weren't ready or aware of it. These are things, unfortunately, that happen in trauma bays across the country, across the world, but we need to think about how do we do this better. What are risk factors for us not doing a good job in the trauma bay? Well, it is a high-stress environment. You do bring together multidisciplinary members of a team that don't necessarily always work together. Are we always clear who's responsible for what? Who's in charge? Is it the ED physician? Is it the trauma surgeon? Is it a resident? Is it a fellow? Is it a nurse? Who's leading that team? We always have limited information in the trauma bay. We don't know what's going on with that patient. We know if we listened, we know what the EMS found, but that may not be the whole story. We often have people on the team who may be unwilling to speak up. They may know something or see something they're worried about, but because of the hierarchy in your trauma bay, because of how their experience and their comfort, they don't speak up. There's clearly multiple distractions in the trauma bay, pagers going off, kids crying in our environment, monitors, everything else are distracting to each other, variable levels of experience, and we always have time constraints. Most importantly, that's a time constraint to figure out what's wrong for that patient, but it's also a time constraint that we have other patients to take care of. We have other things, responsibilities during the day. The goal is here to improve teamwork and communication to achieve safer, faster, more efficient, quality patient care. The team needs to have a common purpose, shared goals. They need to work interdependently people need to be accountable, and there needs to be a collective effort. This is true whether you're talking about your favorite football team or whether you're talking about your trauma team. They need to work. And in order for that to work, we need to communicate well with each other. So one of the key issues with communication is, are we all on the same page? Are we working on the same team? Are we under the same impression of what's going on? One of the ways to think about that is what's called situational awareness. So I use this little graphic here, but think to yourself, what do you see in that picture? Do we all see the same thing? Do we all see the same thing right away? Or do some of us see one thing and some of us the other? There is a man playing a horn. If you look at this image, you see a nose, you see the saxophone here, his feet down here, but there's also a woman. Here's her eyes, now this is her nose and her mouth. So when we think about this related to a trauma patient, what I think is going on versus what another member of the team thinks is going on may be very different. And we need to make sure we're all on the same page, working towards the same goal. The way we get there is through communication. This is the most important aspect of teamwork, but it has to be effective and it has to be free flow back and forth. As my wife will tell me, if she says something but I don't respond and don't listen or don't talk back, that's not communication. And that's true in the trauma bay as well. Someone has to say something, you have to acknowledge that you heard it, you have to respond, you have to make sure you heard it. Just because I say something certainly doesn't mean everyone on the team hears it, doesn't mean everyone understands it, and certainly doesn't mean it happens. So why don't we communicate better? What are some obstacles to communicating here? And Becky and I may or may not hug at the end, so stay tuned. There's certainly obstacles. There's professional relationships. Well, I like so-and-so, or they're my boss, so I have a different comfort level with speaking up. Some people, usually not surgeons, don't feel comfortable speaking up if they don't have enough information. As surgeons, we often speak up whether we have the information or not. We all have different amounts of workload, stress, and fatigue that may make us more or less likely to talk up. And there's always perceptions. It's our attitudes, our beliefs, our teamwork concepts that we come to the table with that influence how comfortable we are communicating with each other. So really the key is that success is dependent upon communication among all team members, right? If it's easier for some of you online to think about this as we need all of us working together to get that beer on the top shelf, or more importantly, we need all of us to working together to not miss an injury, get that child taken care of safely. So what are some tools we can use, right? We all want to learn to do this better. We need tools to help us do it better. I'm going to kind of briefly touch on some of these tools. The pinch, that's that gut feeling we have. Something's wrong, something's just not right. We need to react to that. We need to communicate that to the rest of our team because our hunches, our pinch, are often very accurate. We know something's wrong even if we don't quite know what's wrong. Utilizing a brief and a debrief, kind of get your team on the same page before that patient even gets there. Whose roles, who's doing what, what's our plan, and debrief afterwards. Learn what you can do better. It's easy to do the debrief in simulation, a little harder to do that in real life in most cases, but take advantage of that team and learn what you can do better. We can always do better. We use videotape review. All our traumas are videotaped. So we actually debrief after the fact using our videotapes to learn from each and every resuscitation. The read back or verbal checklist are useful. You'll hear Ben Carey talk after me about the airway checklist that we're using, but any checklist to keep the team on the same page, keep everybody moving forward. If I ask for an order directly to someone, I need to hear that they heard me, they're going to do it, and then I need to hear call out that they did it. That lets me know that yes, not only did I ask for an IV to be placed and fluid to be started, but that IV actually was placed, that fluid was started. Just saying it, although many of us that have been team leaders assume just because I said it, 3 seconds later it's done, that's obviously not the case. We need to think about what's called a sterile team environment. This doesn't mean sterile as in the operating room. This means we're doing something crucial and we need everybody to pay attention, stop talking, stop the other communications and focus on what we're doing. We have to have a sense of dynamic skepticism, always questioning and judging and challenging what we think we're seeing. This doesn't mean we don't trust our team. This just means I want to make sure we're on the right page. We have specifically here assertive statements. Again, does not mean yelling. One time yelling and making someone feel bad for speaking up or making someone feel stupid for something they said shuts down all of your communication. But there also are times where you do need to get the whole team's attention. You need to get people's focus and need to get them moving forward. That's an assertive statement. Finally, there's the step back. We call it a shared mental model. You could call it a timeout. It's this brief moment during your resuscitation that you take 30 seconds, 10 seconds, 15 seconds to kind of make sure your team's on the same page, make sure everyone has that same situational awareness. Ask your team for questions, ask for input. Just because you may be the team leader certainly doesn't mean you know or see everything that's going on in that room. Utilize your team, use that step back. What are obstacles? So if it was easy, we'd all be great at communicating, there'd be no problem, but there clearly are obstacles. There's an authority gradient. Well, I don't want to speak up because that's my boss. That's the professor. That's the director of the ED. That's the director of trauma. I'm going to defer to them. We don't want you to defer to the director or the professor or the person that's been here the longest. Even every person cannot see everything, and every person can make a mistake, and you need to communicate. The halo effect is somewhat similar, but it actually can go to someone that's at your same level, someone that's lower in a hierarchy than you. But this is the sense that, well, that's a really good person. They're really nice. I don't want to challenge them. I don't want to, make them look bad because they always do a good job and they're always trying really hard. Well, that's great, and we want to be teammates, but if it's affecting the patient care, you need to address it at that moment. The passenger syndrome is a sociologic syndrome that happens when there's a lot of people there. We all assume someone else is doing something, or if no one else mentions it, it must not be a problem, and we sit back as passengers instead of being actively involved. We need to be actively involved. Every member of the team needs to be actively involved because people will find stuff. Unfortunately, there's hidden agendas. People don't like someone else in the room that's leading or don't want to listen to them or say, well, they always think they can get this IV, so I'm going to let them try until they take 3 tries and miss rather than help them. We don't want that. That's not in the best interest of our patients. There's sadly complacency. Well, this is as good as we're going to get. We're great. We don't need to keep communicating because we know what we're doing. All of us can improve every day. There's high-risk portions. Are we paying attention to each other? Are we getting distracted by these high-risk phases and losing sight of the big picture? Are we all focused on that mangled extremity and not paying attention to the fact that we're losing our airway? Right? We have to focus. Strength of an idea. One person could say, I think this is what's going on. And if you don't have that dynamic skepticism, you can go down the path and everyone's focused on one idea and not dealing with something else. We have to be aware of task fixation. Again, picking on surgeons as one, we always think we can see everything and we can hear everything even if we're in the middle of a procedure. There's times where that may be true. There's times certainly where that's not true. If I'm in the middle of a procedure, I may not always hear that pulse ox changing. I may not always see that IV fall out. We need to have a team leader who can see the big picture even when someone else is doing a task. And then finally, there's hazardous attitudes. Just this people on the team that just think this whole communication and teamwork thing is stupid and this never works, things never change around here, and therefore don't communicate because they don't think it's going to make a difference. These are what prevents us from having good communication and good teamwork. So I'm going to throw out another question as well. Have people online ever participated in simulation training? Simple yes or no to that question. And then if you have you done it based on just physician or your specialty, or have you really done it as a team? We do our simulations, and I'll move into discussing them here, but we do it as a team because the trauma bay is a team. So there's no benefit to doing this as individuals. So I'm going to talk now really about the role of simulation in improving our teamwork and communication, and an area to practice those tools and work on avoiding those obstacles. So here's another short video of one of our in our simulation center.
It's a 3-year-old coming in by squad with a right lower arm amputation. It was a lawnmower accident, also has multiple lacerations. He's tachycardic. They didn't have access when they talked to him, or when I talked to him, and they just have him on a face mask oxygen. We have some fluids. We just started here, so he's all yours now. He's been awake, crying, talking to us throughout. So I got the transport. We got him 102 Satsabin and a upper 90s, and the heart rate's in the 130s. Okay. So airway is intact. All right. Breath sounds about right. Bilateral breath sounds, femoral and brachial pulse from the butt. All right, everybody. So just listen up so that we are all on the same page. So we have a 3-year-old with partial amputation of the right forearm, multiple large lacerations. We're going to roll him to get the board out from underneath him. We're going to set up for a chest tube on the right, and when we roll, we're going to get a chest X-ray also.
He's still losing a lot of water.
Our pressure is good. We are tachycardic, so we have normal ceiling going. We have blood hanging.
Do we have a tourniquet we can put on this end?
We are not controlling the bleeding. He's actively bleeding from several
Yeah,
sites.
if you want to get a tourniquet, is that helping?
It has slowed down a little bit,
Okay, sweetie, we're going to apply medicine.
and there's some bleeding going on this right thigh here.
Okay.
See if we can give another tourniquet.
Another.
So I think that kind of gets the point, and just to keep the time, it's very realistic. You can make your simulations feel very real. We always have, when folks show up, don't think it's going to be very real and this is fake, and then they move in and get involved, get engaged, their heart rate goes up, they feel engaged, and they lose track that this is a simulation if you run your simulations well. So we started, like I said, about a little over 10 years ago now. Here's some data just showing it's multidisciplinary. We certainly want residents, nurses, anesthesiologists, pharmacists, anyone that's involved in our trauma bay. We want them to participate in simulation. It's a requirement for all our faculty, both ED and surgery, to participate. It's a requirement for all our residents to go through this, and all of our nurses that spend time in the trauma bay go through this. And the graph just shows you that doing these simulations improve our time to key elements like airway management, initial assessment, assessing the cervical spine, assessing the pelvis. We can demonstrate measurable improvements, and other groups have demonstrated similar improvements by practicing in a simulation center. Simulation also impacts patient safety. Our ED group here was really at the forefront of looking at the use of simulation for safety, and really did simulation training across the ED and teamwork and communication training, and really saw it going from pre-intervention 2 to 3 serious safety events a year to post-intervention 1,000 days without a serious safety event. This can improve your care. You can also use simulation in your real environment. The picture shows us doing simulation in the operating room, but we also do simulations in the trauma bay, and here now, out everywhere, pretty much in our hospital, we'll do simulations. The advantage of simulations outside of a sim center controlled environment is that you really learn potential problems that happen in the real world that you might not have identified otherwise, and you can address and fix these problems. These are what we call latent safety threats. Latent safety threats can fall into several categories. They can be medication threats, equipment threats, or resources and system threats. It's much nicer to learn that you might have a problem during a simulation than to learn that when a patient shows up at your doorstep. This is an additional benefit of simulation. So here's one more last video, and this is us doing a simulation that really tried to show some of these good communication as opposed to the earlier poor communication.
This is a 7-year-old that was unrestrained in the front of the vehicle, found him down in the passenger side on the floor. He's got abrasions, came obtundant once we got him out, quieted down quite a bit. Yeah, he hasn't been moving at all. Does have the abrasions, I said, maybe abdomen. We didn't get a good look in regards to it. Once he started going sour, we kind of intubated him and loaded him.
Okay, thank you. Does anyone have any other questions for EMS before
How
we
long
leave?
did it take you to get him out of the car?
It took us about 3 minutes to get him out of the car, and that's when he came up top.
Thank you. We'll let Dr. Wright start your assessment and call it out.
So he has an
check
airway
tube.
intact with an ET tube.
Okay. Can we get, Nurse Wright, can we get an
I'm
IV? Nurse
concerned
Left,
about
can you try an
breath
IV
sounds
also?
on the left side.
Can you confirm that, Dr.
I
Left?
agree, there's no breath sounds on the left side.
Okay. Respiratory, how do you feel the tube position is?
I agree. I think the tube is too deep. We might be trying to pull it out a little bit.
Okay, does everyone feel comfortable if we go ahead and try to move the tube back a little and reassess the breath sounds?
Yeah.
Yes.
Okay, respiratory, can you go ahead and slowly move the tube
Yes.
back? We all concentrate on the tube.
Breath sounds are much better.
Okay,
They're equal bilaterally.
all right, great. Do we have those IVs in?
We
Yeah?
have IV access on the right, 18 gauge.
IV access on the left, 18 gauge as well.
Great.
He's
Can
got
we-
a good brachial and femoral pulse.
Wonderful. Can we go ahead and get bolus, 20 per kilo for this 30 kilo child? Ready?
I'm going to start the bolus for the 20 per kilo bolus.
All right, let's do a quick mental model, everybody. So this is a 7-year-old that was an unrestrained passenger. We had some decreased breath sounds initially, which are better now, correct?
Yes.
We moved the tube back. We don't think we have a pneumothorax. We do have some abdominal trauma. We're starting our first bolus. We're going to go to CT. We're going to have to CT his head and abdomen. Any other questions or thoughts that we're missing?
Oh, sorry.
No,
Good.
I agree.
Okay, let's get him set up and get his bolus and get him moved to CT.
Okay.
So hopefully, just by watching that compared to the first one, you can appreciate some of the things that we did better in that second simulation. I won't lie and say that every one of our trauma resuscitations are that calm and organized, but we are certainly better 10 years later than we were before at looking more like the second video than the first. Key things: we did a pre-brief, we listened, we gave assigned roles, we listened to that EMS report, we directed orders at individuals, we clarified findings if there was question, and we did that shared mental model, or that timeout step back at the end to get everyone on the same page. And a final question here: do you think your institution could benefit from the use of multidisciplinary team simulation, as well as potentially videotaping and reviewing your simulations? So in conclusion, I think the care of injured child clearly requires a complex team come together in a stressful situation. Simulation provides a very safe environment to learn and practice communication skills. We spend a lot of time in the Sim Center debriefing, spending time reviewing what we could have done better, and then go back and trying it again. Simulation video review really provides the opportunity to identify those latent safety threats. You'll hear some more about that in a minute from Ben, how he used videotape review, and analysis can help as we move forward. So with that, I'll open it up to questions as well from the panel or those online. So good news, I looked at the poll. It looks like a lot of you have done simulation and teamwork simulation as well. So I think that's great, and I think I would continue to encourage folks to do it not as a one-time event, but an ongoing training.